Good morning, everybody. I feel like a rock star up here. Thanks. Well, welcome to today's Medical Grand Rounds. An important announcement. This is actually the last talk of the spring series. So enjoy your summers and come back the week after Labor Day. We'll be hearing from Dr. Miles Hassel on September 13th. Today, I'm really pleased to introduce Dr. Marian Hodges. She's a practicing geriatrician, as well as a palliative care consultant at Providence, Portland. She serves as the Bain Chair of Geriatric Medicine and the Regional Medical Director for Geriatrics for Providence in Oregon. Dr. Hodges graduated from Dartmouth College and then went on to do postgraduate studies in theology in Cambridge, England, earned her medical degree from Columbia University and did residency here at OHSU, as well as additional training with a master's in public health at University of Washington. She's the principal investigator for the Alzheimer's disease and related dementias notebook project within Providence, and was quite recently recognized as the recipient of the 2016 Hastings Center Cunniff-Dixon Senior Physician Award. This is actually a national award through Duke University that recognizes leadership and skill in providing outstanding care near the end of life. I think all of us look to Dr. Hodges for her excellence and her role modeling in caring for what are often complex but rewarding patients. She is a teacher to many of us, equally talented at the bedside as well as the classroom. So really delighted to have her come share some of her wisdom with us today.
Thank you, Laura. That was a very nice introduction. Really appreciate that. So hi, everybody. Last one of the spring series. Wow, that's great. Almost summer. First day, second day, right? So today I'm talking about a topic near and dear to my heart, and although the title says how to approach for PCPs, it's a little bit of a misnomer, this title, because really dementia is a team effort. Everybody in healthcare interacts with people with dementia. Nurses, chaplains, social workers, respiratory therapists, CNAs, housekeepers, all of us interact. And this topic is also a little bit different for, I think, a grand rounds from some of the topics we talk about, because dementia really is a personal topic. I would venture to say every single person in this room has a family member or a friend or a neighbor or a colleague who has this disease in one of its forms, Alzheimer's or another form. So this is a personal topic as well as a professional topic. And so I think that there's something in this for everybody today. So we're dealing with an epidemic, people. We don't really talk about dementia as an epidemic, but they say that every 67 seconds, someone in the United States is developing this condition, and we have well over 5 million Americans diagnosed, which doesn't even include all the people we haven't diagnosed with Alzheimer's, and that's just one of the dementias. And if we talk about Alzheimer's in Oregon, we also know that we have a kind of epidemic, because if you look at this graph, the numbers projected to be in Oregon, Oregonians with Alzheimer's over the next 10 years is definitely going to exponentially increase. This is a disease of aging, and Oregonians are aging, as is our country. We're living longer and longer, and so we're having more and more people who have this condition. Now, when we talk about causes of death, we don't usually talk about how Alzheimer's is the 6th leading cause of death in Oregon. And as PCPs, we're usually more comfortable taking care of these people on their way to death than people who are dying terminally from Alzheimer's and Alzheimer's alone, which is a terminal condition for lots of folks. So we're not doing such a great job in how we care for folks with this condition, with dementia. We know that less than 50% of people with dementia are actually informed, or their families are informed of this diagnosis, and this really has a lot of implications, which I'm going to talk more about later. We also know that if we actively address the diagnosis, we would probably change a lot of medications which could be causing harm to people with dementia. And we know that if we actively address the diagnosis, that perhaps there's a lot of care at end of life that we would be discussing and maybe not giving. There may be some TAVRs that we wouldn't be doing, dialysis and other aggressive care that in the context of dementia maybe is not the right decision, but we're not always discussing this head on. So today, my hope is that you're going to walk away with at least one thing that is going to change how you approach patients and families with dementia. Whether or not it's a tool that I give you, and I hope everybody picked up the handout outside, but whether or not it's a tool or some language or perspective, but I'm hoping that something is going to change because of the next 45 minutes. That's my goal. So let's first talk about what is dementia. We want to be clear. And dementia is when at least two of the many brain functions, at least two of them go down, that they are impaired, such that the individual is no longer able to operate safely independently. That's in distinction to mild cognitive impairment or mild neurocognitive disorder, which is when one brain function has been impaired, and only one, memory or visual spatial ability, language, we'll talk more about those, but they're still able to be okay alone. And so what are some of the brain functions? Well, there are many. We tend in this country to always focus on memory, as if memory is everything. But memory's not everything. There's language, my ability to talk to you, you to understand me, you to be able to read, understand what you're reading. Of course, there's short and long-term memory. There's the ability for you to navigate through your space and do it safely so that you have accurate depth perception and that you can go from point A to point B. There's the ability to have what we call executive function, where you're able to plan a task from the beginning to the end and carry it out, whether or not it's writing Christmas cards to everybody and mailing them on time, or planning a dinner party, or me getting this talk together. That's executive function. Then there's the ability to behave appropriately in a social environment and to do your taxes. All of those are functions of the brain. Whoa. Oh no. That's okay. Okay, that's Mom here. This was my mother's. So what kinds of dementia do we have? Well, Alzheimer's is the most common cause of dementia, and actually lots of families don't realize that Alzheimer's is a dementia, that you know, they hear the word Alzheimer's and has so much stigma in our country that they can't necessarily understand anything else. It's kind of like breast cancer was in the 1970s. But Alzheimer's is the most common form of dementia in the United States. And then vascular is the second most common. And then there are a whole host of other dementias. And some of these other dementias include mixed dementia, which can be Alzheimer's with vascular, and that's the most common, but it can be Alzheimer's with Lewy body or with alcoholic. It's a combination of Alzheimer's and any one of the other dementias. We're diagnosing Lewy body more and more than before. But that's a distinct condition where the person usually first presents with a motor disorder. They're falling more, they're shuffling when they walk, and they have visual hallucinations early on. So this is a condition which happens younger in life, and as I said, we're seeing more and more. Frontotemporal dementia is really a disorder of disinhibition. The frontal lobe is damaged, and so the person is more likely to curse, to engage in more sexual behavior, to eat more impulsively and binging. And that happens to younger people. And then there's dementia with Parkinson's and HIV and alcohol. And so we're not graded very well by the families in Oregon and how we're doing with dementia. We had 7 town halls in 2011 asking families, you know, how are we doing? And what they told us, and this is a few of the quotes, is that they felt dismissed by a lot of PCPs. They felt that the PCPs either said, well, you know, there's nothing I can really do about this, or, well, you know, when you get older, you get dementia. But they weren't really told, how do I navigate this journey? What do I expect? When should I call you? When should I not call you? They had real active concerns which they felt were not heard by the patient's PCP. And so they were asking us to do something. And you know, we can do something. We tend to approach dementia a little bit fatalistically, but there is something that we can do. And so first of all, we have to think about it. We have to look for it. And so there are ways to have red flags pop up for you that maybe you haven't thought about before. So that whenever you have a hospital visit, you know, a post-hospital visit in your office, and you know that that hospitalization included an acute change in mental status, delirium, that's a red flag that that person's brain is likely not normal, that they had underlying either mild cognitive impairment and or dementia that may have not been recognized. And now we're dealing with a patient post-delirium who may not ever get back to their previous state. So we need to be worried about that person. For the families reaching out with concerns, grabbing you in the hallway, calling you on the phone, saying that dad is different or my husband is different, we need to pay attention to that. For the patients who consistently show up wrong day, wrong time, that's a red flag. I recently had a patient actually transferred to my practice from a different clinic where he was on a regular basis showing up at the wrong time. And that really wasn't being picked up by that clinic. And the family felt, again, that the patient wasn't really being attended to for his cognitive deficits. And then if this is happening, all of a sudden the patient's not coming alone anymore. The family is there to help with the history, write down notes. That's a red flag. So those are big red flags. But there's some more subtle things that we can see in the office visit. And we, again, as primary care docs, for the studies out there, we don't always detect dementia when it's actually looking at us within the office visit. So if your patient is vague in the history, everything is fine, you know, you get one-word answers, you don't get paragraphs, that's a red flag. If they're looking for their family members to give you the history, and they don't really know, or they hedge and say, well, you tell them. If they repeat themselves within the office visit, tell you the same thing more than once. And of course, the more subtle is the one-liners. I had one gentleman who every time I asked him a question told me an elephant joke. And you know, it was very amusing. And his social skills were impeccable, and he was impeccably dressed. But I never got any content from any of my questions, except for fabulous jokes. So the evasiveness is a red flag. And or new psychiatric symptoms, which now we understand, particularly late life depression, those patients are twice as likely to develop Alzheimer's in the next several years and or vascular dementia than patients without late life depression. So that's another red flag. So everybody, if you have your hand out, please take it out. I'm going to talk to you about the Clinical Provider Roadmap, which is a product of our State Plan for Alzheimer's Disease in Oregon, or SPADO. And this is something that since those 2011 town halls has been an effort by a multidisciplinary group to really help primary care doctors feel more comfortable in navigating this disease. Because I think, as most of you know, there are not enough geriatricians, there are not enough neurologists, there are not enough geropsychiatrists to handle this condition. And so this is the overall roadmap. I'm going to break it down for you. There's the initial assessment at the annual exam, your annual wellness visit, and or if you've had one of those concerns, one of those red flags trigger you to do this assessment. And if the scores are in normal range, fantastic. And if they're outside the normal range, that's when we do a more in-depth cognitive assessment, which I'll discuss in a minute. And if those scores fall outside of normal range, then we're doing the dementia workup. So let's break this down. How many of you have done a mini cog? So many of you, right? So this was really brought home for many of us as part of the annual wellness visit a few years ago. But this tool is a great screen for dementia. Now, little caveat, a lot of people don't like the word screening applied to the word dementia, because usually when we talk about screening, we talk about finding something early that we can then impact, cure, or ameliorate. And we all know that we don't have great drugs for dementia to cure it or even to really do much amelioration. However, looking for it is important, and we'll talk more about that. And the mini-cog is a great tool to look for it. It's simple. You give them 3 words, and they give you and then this is also in your handout, 6 different combinations of 3 words. Banana sunrise chair is a popular favorite. You ask them to repeat it, and then you ask them to draw a clock. And so I usually do the circle, and then you ask them to do the numbers 1 through 12 around the circle in the proper place, and then they ask them to draw the hands to say 10 after 11. Takes 3 to 5 minutes, and by far this is the most sensitive and specific screen we have. And it's very important that the numbers are spaced correctly and that the hands are also in the right place. This obviously is not a correct clock, up to 13. I've seen some numbers up to 30. I had a resident tell me the other day she had somebody go up to 60. And so, we can see definite disorders in visual spatial function by doing a clock, as well as this is a test for executive function.
Why is it always 10 after 11?
Yeah, well, that's a good question. I think because that was where the hands were spaced in a certain way, and so they could kind of get a good idea. You can also use 8:20, that's the other time they like. But this is what the examiners and the research found. So if you have an abnormal clock, that's an abnormal screen. And that sheet that I gave you talks about the other ways that the mini-cog is abnormal, and that's particularly also if you can't remember the 3 words, which is what you ask them after they do the clock, to tell you again the 3 words. And if there's 0 of 3 words, that's also a failure. Well, if somebody doesn't do well in the mini-cog, if they fail the mini-cog, that's a red flag that they may have serious cognitive impairment, but I don't then, in that visit, go further. I bring them back to do the next steps, because I find that they might begin to get a little antsy after the mini-cog. We don't want to alienate them. So I bring them back, and I do a more complete history. And what I'm really trying to do here is trying to find out, is their daily function impaired? Are they having trouble living independently? And they usually can't tell me that or won't tell me that. And so what I do find out from them is what medicines they're taking, and hopefully we can get an accurate med list. Bringing in the brown bag helps, because many medicines can make their cognition worse. We also, if able, find out, are there cognitive deficits that they can talk to me about, and if they can't tell me, the family. And if the family can't tell me in front of the patient, then I need to do that history separately. And then I'm looking for some psychiatric symptoms. So it's mostly history, which is not an easy history because all of it is not coming from the patient. And this is a very helpful tool that the family can fill out to give you an idea of the function. This is called the 88 screening interview. It's also in your handout. And here are functions such as trouble handling complicated financial affairs, trouble remembering appointments, trouble learning how to use a tool, appliance, or gadgets. These are the things that give you an idea that the patient's no longer able to operate in their world independently. And if they check yes, a change on 2 or more of these, that's a positive screen. How do I use the AD8? Well, sometimes during this office visit, I slip it to the family kind of secretly. They fill it out while I'm doing the physical. And or at the end of the visit, I sometimes hand it to the family, and or I've mailed it. It can be a little bit a source of tension if I hand it to the family directly in front of the patient, because then they're like, what's that, what's that? So it's something that I have to finesse. Medications. Why are the anticholinergics so important in this review? Because we know that with dementia, those plaques and tangles damage neurons, and in damaging those neurons, the levels of acetylcholine in the synapses fall. So one of the reasons why their cognition is impaired is they no longer have normal levels of acetylcholine. We give a patient with Alzheimer's anticholinergics, which are all over our formulary in opioids, in our antihistamines. Benadryl is a popular problem. Antipsychotics, in the antispasmodics, such as ditropan, or all the other bladder incontinence medicines we give. In our antiemetics, in tricyclics that we give for neuropathy or depression. And so I sometimes have new patients with dementia who come to me who are on 4 anticholinergics. And just by taking those away, their cognition can improve. These other medicines that are psychoactive can make for worse cognition, as well as anything that causes their cerebral perfusion to be less than adequate. The physical exam in such an evaluation usually is normal, especially with your patients with dementia from Alzheimer's disease. But you want to make sure that their hearing is okay, because if they're answering your questions wrong, it's possibly because they didn't hear you correctly. And also to look for any focal neurodeficits. Particularly, we're looking for possible vascular dementia or Parkinson's or Lewy body when we might see increased tone or tremor. And finally, let's talk about cognitive testing. So the 2 tests that are easiest for the primary care physician to use are the SLUMS and the MoCA. And some of you, depending on your training, have been trained in one or the other, but use whichever is easiest for you. Both of these are also in your packet. The SLUMS, 5 to 10 minutes, tests multiple functions of the brain. And the way I introduce it, and this is incredibly important, is in this exam, in case they're beginning to get a little nervous, I say, hey, we're now going to do a test that I do with all my patients, and it's going to test your memory as well as some other things. But I do this with everybody who is 70 and over or whatever. But I normalize it. I try to make them relax, because otherwise I've seen patients after I've gone to question 3, they just refuse to go any further. They just say, I don't want to do this anymore. So I think if we normalize the test, that really helps. The MoCA takes longer to do, but this is the preferred test if you think the person may not have Alzheimer's, if they may have vascular disease or Lewy body or some other dementia. This is the preferred test, and it's available in multiple languages. Some people ask me about the mini mental status exam. That's being used less now because, quite frankly, it's licensed and you're supposed to pay to use it each time, $1.80, I think. But in any event, it's also not particularly useful to detect mild cognitive impairment, so that's no longer as useful. In your handout is this very nice chart that is courtesy of the Legacy Geriatrics group. We're kind of friendly across the city here in geriatrics, so we're okay with using each other's materials. And in this grid, you see across the top are the different dementias, and down along this side are the different symptoms that we assess for, including memory, attention, motor signs, et cetera, and the differences between the different dementias. And I would suggest to every resident, every medical student, every PCP in particular, this is a very helpful way for you to distinguish the different disorders. After your physical exam and history, there are a set of labs to do that are basically to rule out things that we don't want to miss, hypothyroidism and low B12. And a vitamin D less than 10 probably is going to affect your cognition. So we're looking for really low vitamin D here. Imaging. Now it's become pretty much the standard of care that we get an image. It used to be that we really reserve them for people with neurodeficits, but I think that everybody feels a little bit more comfortable if we've ruled out that there is no mass, that there is no subdural. But certainly you want to image if you have any of these concerns. Somebody whose changes have progressed rapidly, who's had a history of head trauma, or who is younger than, I would say, 65. How about biomarkers and PET scans? Well, lots of data are coming out. There are studies that are emerging, but right now it's not really for prime time in the PCP office. We just don't have enough now to advocate for routine use. Okay, So you've gotten your labs, you've gotten your image, you've done your physical, you're ready to have the family and the patient come back for what may now be visit 3, but you're not sure if it's dementia or what kind of dementia. The scores were just not low enough, or the presentation was not clear enough. And so we do have some resources that can help you. Our outpatient OT evaluation is something you can order where they can do the Allen cognitive level, which is very helpful for trying to figure out not only the different brain functions that they analyze. Again, it's an in-depth study of executive function, visual spatial, but the test has been well correlated to see how well somebody can live independently and how much supervision they may need. Neuropsych evaluation is a bit harder for me to recommend because although it's a very in-depth study of the different brain functions, it's really dependent on the examiner, to me, how helpful the write-up is. And so I think if you have a really good neuropsychologist that you've worked with and feel comfortable that their assessment can help you, great. But not all the evaluations are of similar worth. The Cognitive Assessment Clinic here at the Brain and Spine Institute is a fabulous resource for you, particularly not for your kind of typical presentation of Alzheimer's, but for your dementing illnesses where you're not exactly sure what's going on and you'd like more help. And Dr. Mega used to be here at St. Vincent's, but we're about to have Dr. Hoyan Zhang, who's a neurologist specializing in dementia, and is going to start in August, and I'm very excited about him coming here to support Christine Bloom and the rest of the group at the CAC. But now it's important for you to disclose the diagnosis. And our problem in America, to be honest, is not only that we don't always diagnose dementia, but then when we do diagnose it, a recent study from the Alzheimer's Association showed that only 45% of the time did we actually talk about it with the patient and family, which means that there was another 45% of charts which had the diagnosis on the problem list, but it wasn't disclosed. So half of the time it was disclosed. And why is disclosure important? Well, no, we can't cure the disease. No, we can't really give medicines that stop it. But there are some things we can do. We've already talked about how we can change the medication list to improve potentially their cognition. For vascular dementia, absolutely we need to modify any risks that could contribute to vascular disease, and that's probably also a good idea for Alzheimer's disease. But mostly this is now about advanced care planning and support of the family. And advanced care planning, not only making sure that while this person, particularly if they're early in their disease, fills out their will, make sure they have the durable power of attorney, make sure that they've thought about end-of-life care, but that they do it when they can have an impact on their future, and for the family to be able to get some support. And so I bring the family and patient back for a third time to disclose the diagnosis, and this is like a telling bad news visit. This is about a warning shot. This is about how much detail do you want me to reveal? But I definitely make sure that they understand that they still can have good days and bad days, and that I'm there for them on the journey. And I often liken the situation to brain failure. Families understand heart failure, they understand kidney failure, they understand liver failure. Well, they also understand when I say, hey, your brain isn't working like it used to. It's failing in certain ways, and they can understand that. And although we have, let me put it differently, we have a scale called the FAST scale, also in your packet, which describes the typical 7 stages that someone with Alzheimer's will have if they are able to live that long and die of their dementia. And we diagnose most people in the moderate or middle stage. We do catch more people nowadays in the early stage when they're having trouble with their bills, when they're having more paranoia, when they're more apathetic. But this is a helpful tool because it really gives you an idea of the typical progression and give the family an idea. And so when I talk to the patient and family about the diagnosis, I also want to give them resources. And yes, Help Us Here is a book that I co-wrote with the daughter of one of my patients who died of Alzheimer's. And we wrote it together because we realized that we weren't happy with the resources out there to guide families along the way. What was on the internet and what was available through organizations did not feel as emotionally supportive and as practical as the tool we wanted to have available. And so Ann Hill and I wrote this together. Many of you have already seen this in the Providence Medical Group clinics. We also have it available online, and all proceeds go to our foundation. I also had available for you out in the hallway this brochure, which is new, Services for Older Adults. It's not just for patients with dementia, but for any elderly person in our Providence family. And then you are on a team if you're taking care of somebody with dementia. You cannot do this by yourself, and your care manager in your clinic is one of your most fantastic allies. Not only to help guide the family about transitions of care and moving, but also to tell them about potential support groups in the community and other community resources. Other resources in the Providence network include our OT driving assessment, which currently is only over on the east side, but Erin Breyer, OT on the west side, is being trained by Anita Dunsmore. These driving assessments currently are not covered by Medicare. I hope that changes in the future because they're incredibly valuable if we're trying to get somebody to stop driving. And then there's elder law attorneys and some other additional websites that I have noted here. My hope is that in the future, the geriatrics program in the Providence Brain and Spine Institute and potentially other programs within the Providence family will come together to develop a more seamless dementia care pathway for our patients and families. Because right now the care is still too fragmented, still too difficult. We have such a long way to go to make this better. But I'm happy that the Brain and Spine Institute and Dr. Zhang, who's about to come, want to partner with us. This is a graphic also in your handout about where the family can think about going next once the diagnosis has been made. And again, here are multiple issues to consider. This is a complicated disease, but sometimes the connections consult can help. Sometimes it's making sure that you've done some case management or even consider referral to elder place. Other things to think about. So what do I tell families? Well, this is where language is your tool, okay? This is like palliative medicine. Words matter. Words matter. And to make sure they understand some of the things that they may see and don't get, like the fact that some days their family member seems totally normal. How can they have dementia, Dr. Hodges, when today they acted like they did before? Well, because the disease, especially early on, waxes and wanes. And you have to tell them, hey, your world, you can change. You can change how you operate in your world. They can't change. So when they tell you that they went to Chicago yesterday and saw their brother who's deceased, you can't argue with them and tell them that didn't happen. You're not going to get anywhere. And so for us to encourage them to leave their world behind and go to their world is a very important thing to do. In fact, that's the one way that you're more likely to have less tension and more good moments with your family member. And this is a very tragic thing when family members endure harsh, even just vicious language from the person with dementia. I hate you. And they endure that and they think, wow, my mother really hates me, as opposed to that's the disease talking. And I've had family members suffering for years because they thought that their mother really meant those words. So we need to counsel them about that, which gets to this point, that when we're dealing with someone with dementia in the office, who's the real patient? And we usually think the real patient is the one with the chart. We usually think it's the person we're actually typing about. But the person who is often suffering is not that patient, but the family member. So let me tell you just two brief stories. Jack is my patient, but I also take care of his wife, who lives in a private home with Jack. And he came to me on an independent appointment without his wife, and mostly spent that visit talking to me about how His wife is no longer the companion he used to have. The emotional intimacy is gone. He can't relate to her anymore. He feels so lonely, so isolated, and he even feels guilty when he sees other women in their community that he wants to be better friends with. What kind of husband is he? And he cries in the office with me. Or Mark, the son of Bob. I take care of Bob and I take care of Bob's wife. Bob's wife has dementia. But Mark calls me because he's not worried about his mother with dementia. She's doing fine. He's worried about his dad because his dad now no longer is seeing his friends, no longer is doing his hobbies, looks down all the time, seems stressed. He's worried that something bad is going to happen to his father more than he's worried about his mother. And so although disease is with the person with dementia, and I'm trying to ameliorate their anxiety, I'm trying to make sure that if they have paranoia, I pay attention to that and potentially treat that. But the suffering is often not with that patient. They may not even have insight into their disease. The suffering is with the family member who is looking at their loved one, often their loved one, but maybe not their loved one, but their family member who they care about at some level, and they no longer recognize them. That's not my mother. That's not my mother who swears all the time or who is mean or who hits. That's not my mother. So caregiver burden, which we used to call caregiver stress, is something very real and something that you're seeing in your practice whether or not you even know it. Because you may be caring for not the person with dementia in your primary care office, but you may be caring for the family member. And you may not realize the social, emotional, physical, spiritual, and financial suffering that they may be having because they can't talk about it unless we open up the chapter. We know that we have 15 million caregivers in America at a minimum. And the unbilled, unpaid care that they provide is staggering. And the thing is, there's work to caregiving, right? I mean, there's physical work. You're helping them with their activities of daily living. You're helping them with their bathing. You're helping them with their bills. You're helping them with their shopping. When does work become suffering? When does it go over into that area? And we don't really understand that entirely. But this study by Kim several years ago actually did study 300 caregivers of persons with dementia. It was a phone survey that he did. And he was trying to figure out which ones were more likely to have caregiver burden. And he found out that the biggest risk were, first of all, if the person with dementia was very impaired, if the caregiver had to do a lot for them. But then the demography of the caregiver was very important. If the caregiver was the spouse, was older, and was living in the same household, that person was definitely at more risk for burden. Why? Well, first of all, they may be sick themselves, right? They're older and have comorbidities. But also, here they are, married to somebody or in a partnership relationship where they may feel trapped. They may feel this is my duty and honor to take care of this person no matter what. And it may be very hard for them to ask for help. And then the third factor that was important as a risk for caregiver burden was the number of hours devoted to caregiving. And they found in this survey that these caregivers, at a minimum, were doing 25 to 50 hours of what they would call physical work. But that's not even accounting for the 24/7 emotional responsibility that they feel for this person. Their caregiving never stops. It just has different forms. So the Alzheimer's Association has looked at this caregiver burden. And what I don't like about the term caregiver stress, it almost sounds like it's a psychological thing. It's way more than psychological. But yes, there's the emotional stress of caregiving, and the blue bars refer to high to very high. And then there's the physical stress of caregiving, which is, by and large, not as dire for them as the emotional stress. But the financial stress is not to be understated. This was a slide I took from Dr. Callahan from IU, and he showed that families of persons with dementia are more likely to spend $100,000 more during the course of an illness than other caregivers. So how do we help the family or friend with caregiver burden. How do you help these people in your practice? Well, I wish that Epic made it easier for us to identify the primary caregiver. And I'm hoping that we can change that someday. But what I do now as a temporary move is I make sure in every office visit I document which family members are in the room. And that's not to say daughter present, which daughter present. And I name the daughter's first name or the son or the wife, but I make it clear how they participate in the visit and what the discussions include. This is not just a primary care responsibility, but understanding, helping them understand their role and how to make sure they have the skills necessary to caregive. That's something your care manager can help you with. Make sure they get the classes in the community, or else the emotional support, and or hire private caregivers to help them if they are physically exhausted and need assistance. And then the other thing that I think is the hardest is to recognize that this disease can go on so long. And the caregiver isn't just going to be the same throughout that journey. And so we regularly, ideally, are assessing where the caregiver is at. In an office visit, how exhausted they look, how irritable they seem, quick to snap if the patient maybe gives the wrong answer. That's all important for us. So it's true that when we screen for dementia, we're not screening because we have Aricept and Aricept makes it all better, because we know that's not true. But what we can do by identifying the disease is recognize which families are suffering and which families we can help heal by our attention to them and our support. And in 2016, that's important while we wait for the advent of medicines and other interventions that can really help the patient more than what we can do right now. Okay, in my final minutes, I'm going to transition to a couple of other things. We didn't talk about Aricept today because we can't really say much that's very helpful about that. But here's something that you do get asked all the time. You don't get faxes in the middle of the night, will you give Aricept or not? But you'll get faxes in the middle of the night about a case like this. Or you'll get a desperate call. Because here you have, and this is a case from my practice, 90-year-old woman who's just moved, and in her first week, she's hitting, she's spitting, she's wandering to other residents' rooms, and the foster home caregiver is ready to boot her out the door. So, what's all this about? Well, first of all, the behavioral and psychological symptoms in dementia are more the norm than the exception. They happen in at least 70 to 90% of patients over the course of their illness. They take multiple different forms of behaviors and or psychiatric symptoms. And part of the problem is they get labeled, these patients, as agitated, aggressive. But what's the underlying tone there? Bad patient. As if they're responsible for what's going on here. But what would you do if you couldn't tell somebody what was wrong? When babies are tired, hungry, scared, they cry. And we don't say, bad baby, right? But here you have an elderly woman who's hungry, who's scared, and if she starts hitting or spitting, that's her way of trying to tell us something that is wrong. And so we need, and I'm asking you to reframe how you think about agitation and behaviors in dementia. Because what we really need to do is think about the underlying cause. What's going on with this person such that they're having these behaviors? And this should be our first response, not to go to the prescription pad, but to talk to the caregiver and or the family member. Could they be constipated? Could they be cold? Could they be lonely? Could they have a new medicine? Could they really not like that roommate? I had one patient who hit every time she saw a certain person in her memory care unit. Didn't like that person. And so once we separated them, that was better. I had a nun patient who every time her brief was changed would hit. And we realized that she was a very private person. To be exposed like that really kind of violated her personal space. And once we changed how we did the brief changing, once we made sure that the sheet was over her and she wasn't exposed as they changed the brief, she stopped hitting. There aren't great studies about non-pharmacological approaches. But I think the most important thing is for us to be thinking about what's the cause, what's the unmet need that's causing this behavior. And then to make sure that we're not trying to tell them, no, you shouldn't hit Betty. That's not the answer. Medications. Well, we're asked to treat a range of different behaviors, and there's no one medicine that really fixes these behaviors. We do have data that shows that the atypical antipsychotics can be helpful when you have patients who are causing physical harm. I had a patient recently at a residence in memory care who hit and, I shall say, physically harmed 6 different caregivers who had to file for workman's comp. 6. And in that situation, yes, I had to try and give a medicine because we were really beyond all that we could do with non-pharmacological interventions. But they come with the risks of increased mortality, increased risk for acute kidney injury, and our professional societies say they're not a good idea unless you're absolutely exhausted everything else. This study several years ago really was the rage because the hope was citalopram might be able to help us. This randomized controlled trial, which had 186 patients, did show that those on citalopram were less agitated. The only problem was they used this dose of 30 milligrams before the FDA came out and said, not a good idea because 30 milligrams is more likely to cause QT prolongation and worsen the cognition. So now we're really supposed to not go above 20 milligrams, and that hasn't been studied yet. This slide talks about what I do right now. And I think the most important thing, again, is to try and find the underlying cause, to redirect. But for those at acute risk to harm self or others, I prefer risperidone or low-dose Haldol. And then consider referring to Providence Home Health mental health nurses. They can be very helpful to go out and see what's going on in the home. Okay, and finally, end-of-life care and dementia. This is a fatal illness if you don't die of your heart disease or your COPD or your cancer first. And many patients, because we diagnose them late in the disease, die within 4 to 8 years of the diagnosis. I've had some who've lived way longer, but this is the average. How do they die? Well, most of them, to be honest, die of infection. They either have more and more trouble swallowing as the disease progresses and they aspirate, or the natural history of the disease is they begin to lose weight because they become anorectic, they eat less, and so their immune system is more impaired, and they develop decubiti, or they develop a UTI with sepsis. These are things I tell the family because they're interested. How is she going to die? How is she going to die? But what we also know is that artificial nutrition does not help. Giving them a PEG tube does not prolong their life. We don't have data to suggest that, or that it helps decrease these different complications. It does not decrease aspiration pneumonia rates, and it doesn't help their comfort. And the American Geriatric Society, at long last to many of us, in 2014 published a position statement to this effect, that feeding tubes are not recommended in end-stage dementia, and rather hand feeding is what they suggest. And hand feeding, you know, I think of it as comfort feeding only. You take the spoon and you feed the person with dementia, and what are you doing in that action? You are having an intimate social experience, potentially, and maybe the only intimate social experience they have during the day, as opposed to hanging a bag of Jevity and walking out the room. And if they clamp down on the spoon and they don't want to eat anymore, well, then you stop. You feed them as long as they want to. But that can be a real meaningful experience, and one that we also have seen to be as or more beneficial than tube feeding. So my takeaways from today are these: that we have a lot of undetected dementia in our outpatient practice, that yes, you can be more comfortable with diagnosing this disease, and I'm asking you to go out there and use this tool. I'm empowering you to try and look for more dementia, and then support those family members. Divide that diagnosis up over multiple visits. Make sure that you document the diagnosis and disclose it to the patient and family. There are multiple resources that are available, including Help is Here, and we have some copies outside if you'd like to take a look at it. Think about caregiver burden, and make sure that you reframe that agitated behavior. I mean, I wish we had different words than agitated, but that's a lot of what we hear. But this isn't a bad patient. This is a patient who is vulnerable and can't tell us what's wrong. These are some apps from the Alzheimer's Association I just wanted to make sure you knew about. They're easy and free. And also the American Geriatric Society has some apps, including this great book, Geriatrics at Your Fingertips, which you can get on your phone. Thank you very much.
Marian,
Yes.
Sleep disorders, relationship to dementia, chicken or egg?
So the question is sleep disorders related to dementia. We're seeing that, that sleep apnea can be a risk for the diagnosis. I can't say much more about that. I mean, I've seen that, but I don't know if anybody else has more to contribute to that. Yeah, can't say too much about that, Kurt. Yes?
Do you place caregiver fatigue or caregiver burden on the caregiver's diagnosis list?
Yes, I do.
Do you have a SB9 or 10?
I don't know the number, but I've put in caregiver stress, because that's right now what Epic will read. They don't have burden, and that will come up.
Thank you.
You bet. Yes,
So,
Claudia.
patients, this is great, and I have to tell you, your book is fabulous for patients. Thanks for that.
Thank you.
You know, family members will often ask, you know, do I need to keep them up during the day so that they will sleep at night? And it's never been clear to me whether or not the need to reorient their day-night was actually helpful for their orientation, or just because it allows them to fit into everybody else's schedule.
Yeah, right. Well, their day-night cycle definitely gets interrupted, and I think the people who are affected most by that are family caregivers who are trying to sleep at night, because in memory care, they don't, you know, they can do whatever they want. So I think that's a difficult question. I mean, it is true that with this disease, there's more fatigued. Their brain is best in the morning. So if there's anything the family member wants to do where they really want them awake and alert and at their best, it's the morning. And they get tired. And as the disease progresses, naps are common, and they sleep more and more and more. And so I think that effort to try to keep them up during the day really depends only if it's for the family caregiver's schedule, because otherwise I don't do it. No. Yes?
What are the hereditary aspects of this disease?
Yeah. Well, there is hereditary risk. The greatest hereditary risk is if the person who has developed Alzheimer's has developed it at a young age. So the people who develop the disease between about 50 and 70, but particularly 50 and 60, the Rita Hayworths of the world who got the disease very young, those are the people whose family members are at greatest risk. But if your family member gets it later in life, which is the most common reason, we are learning more and more about the hereditary aspects, but yes, that will make your risk more than somebody whose parent didn't have Alzheimer's. Yes?
Hi, Mary. I realize as you went through this that in my own experience in the last 10 years or so, we've made a lot of progress in being proactive about the diagnosis. And there's a lot to do, but we're doing a lot better. I realize in my own practice that where I'm really falling down is in this kind of daisy thing of important issues to address once
Yes.
the diagnosis is made.
Yes.
I'm being really, really reactive. I wait for one of these petals to fall off of quality of life or safety or living arrangements.
Right.
And I'm not sure I have a question here, but more, you know, you're someone in position, so maybe help, like an annual dementia wellness visit or
Yeah.
a proactive approach to these petals would
Yeah.
prevent a lot of suffering, I think.
I couldn't agree more, Alex, and I think that this is where, you know, I've talked to Mike Schmidt and John Zaraski of the Brain and Spine Institute. I mean, I think what we would really like to do is figure out a better pathway for us to recommend to our primary care providers and for us to be able to support as Providence, because really, I mean, this is an overwhelming task, okay? Let's be honest. This is not simple. This is maybe the hardest thing that we are dealing with in primary care for many of us, because of our inability to actually help in the traditional way, how we've been trained in medical school. And yet the behaviors, the need to move, the need to make sure somebody is safe, all of these things challenge us in ways that impact the community, impact the family, impact us, impact our society, impact cost. So I'm glad you brought that up, and we're going to work on it. How about that?
No, even a suggestion that this DAISY could be made into some simple epic tool.
Yeah,
To help me. in
that's
the
a great
moment to
idea.
Remember, dementia care, and those 8 things show up. Have I thought about that at some point this year?
I like that idea. Maybe we can get to work on that, Alex. Thank you. Yes.
So,
Yeah.
excuse me, that was great, and I love the idea that we have to share with patients more when the diagnosis is made. When it's not a diagnosis of dementia yet, but there's clearly mild cognitive impairment, how soon do you make it a priority to talk about that with patients and the risk that that means for sort of eventual dementia?
Yeah. So we're learning more and more about mild cognitive impairment. And it is a risk for dementia. Not all of them will develop dementia. In fact, some of them will get better. And we know also that right now, if we give medications like Aricept or some of these other medicines, they don't help mild cognitive impairment. So there's nothing to right now give to these people. So first of all, do you disclose the diagnosis? And I usually do, especially if the patient is sitting there at the end of whatever test I've done and they look really worried. Like, what are you thinking? I talk to them and I say, well, you had some trouble with this. You don't have dementia, but your brain is not quite as sharp as it was, and we'll follow this. And we call this, mild neurocognitive disorder or mild cognitive impairment. And then I do think it's useful to repeat your tests along the way. They say, our data suggests that the slums is better as a screening and not so great as a following mechanism, that the mini-mental is better for that, but the mini-mental is also something we're supposed to pay for. So our tools are also not as perfect, but I sometimes will use the MOCA in separate years, and even sometimes I use the slums, although it's really meant to be just a screening. But you're really trying to track how their brain is doing. And often the way you know that they're different is that the families are telling you that they're different. Yes?
Questions from the perspective of a friend, not of a physician. A good friend of mine, not a lifelong friend, not a friend of the family, but he's well along in advanced dementia. Is there value to him for me going and sitting there and talking and so forth?
Well, yeah, I think
Do I
that...
feel embarrassed by not doing it?
Yeah. No, that's a great question. Everybody hear that? The question is, if I have a friend with advanced dementia, is there value in me going to visit them? So one of the greatest sources of suffering for the patient with dementia and the family is how isolated they become, because their friends stop visiting, the neighbors stop coming over. I mean, people don't always know how to act around them, and so they disappear. And that is incredibly common. I would say that's more the norm than anything else. But I think for you to go and sit with them, even if you're not able to ask a question that perhaps they can answer, but still to talk to them, to reminisce with them, to listen to music, watch TV with them, but to give them social interaction has incredible benefit. And that's part of the way that we do help alleviate some of the loneliness that these patients suffer from. Yes, thank you for that question. Yes, last question, Claudia.
So I know you really didn't want to talk about meds, but
It's okay.
if you were to start
Yeah.
medication,
Yeah.
how do you decide whether to keep them on it or not?
Yeah. So I pretty much give everybody a trial of Aricept because that is the standard of care, and unless they are first coming to me and it's clear that they're at the end of their disease and comfortable, but most people I give a trial. And I start with 5 milligrams, and then I increase it to 10, usually after a couple of months. I don't do it too quickly because they tolerate it better if I wait. We know that Aricept can be effective in retarding the progression of the disease in all 3 stages, early, mild, and late. And we used to think that we should stop it after a couple of years. And now the recommendation is really to keep going until really they are ready for hospice, and then to stop it. So because it used to be that when we would stop it because we thought we should, then they often got worse. And so we would put it back on. So I now keep it going until pretty much the end.
So you just assume if they're tolerating it, that it might be helpful.
Yeah, and I used to think, oh, well, they're probably not benefiting. The family would say, I don't think they're really benefiting. And that's when I've done tons of trials of taking it away. And then, whoa, that really was helping. Now, sometimes you take it away, especially if they're having trouble swallowing or something else, and you don't see a difference. But I would say 7 to 8 times out of 10, they got worse when I took it away. And the recommendations now that I see are to continue it. Yes, Dr. Cohan?
I think if you're going to use a drug like Aricept, one of the things that's important is to give the family some clues about what they might expect the drug will do. People are so focused on memory impairment.
Yes.
And as a matter of fact, the scientific rationale behind the development of Aricept was that in using anticholinergics, you produced amnestic disorders. So therefore, if you use the procholinergic drug, essentially, but frequently it's not memory that might improve. People may be better focused, may be more engaged,
Right.
and they'll function at a higher level.
Right.
Only because they're paying more attention, and that's a very worthy response. So it's very important to prepare patients for the idea that there are a number of different ways in which the drug may help, and the fact that their memory has not improved, don't be put off by that. There may be some other ways that the Aricept is helping them.
Yeah, no, that's very well said. I often tell them that they'll track better. It's kind of like they'll be better focused, just as Dr. Cohan said. And families, often see that, although it doesn't happen right away, so it can take a little time. All right, well, any other questions, please come up to the front. Thank you very much.
Very, very